All right, well, thank you. I'm super excited to have you guys all here. This is something we've talked about for more than a year of wanting to put on as like a regular, just nothing extravagant, just a evening lab night and go over different topics. So we have, y'all have this flyer. We're obviously doing the one tonight, and then we're going to do a couple more that are just kind of digital dentistry focused. We, in the lab, seem to get a lot of questions around these topics, so we thought it'd be fun to formally go over it and just see how it goes. Like always, our format is pretty informal, where ask questions. We're here to have more of a discussion than for me to lecture at you, which we'll do some of that anyway. But that's the goal. And then obviously, our goal is to get people into the lab because we like working with people on lab stuff, and but we feel like it really is relationship first, and then if that works out and we can be a value add, then great. But we're also just pretty collaborative there, where if you have questions and you already have a lab that's working for you, we're still happy to help you out. So let's get started. Oh, come on. Okay, are you clicking for me? So it did work, it was just delayed. Great. All right, a little bit about me. I graduated in 2013 from OHSU, and I've been around a little bit, spent some time down in New Mexico. But when I was still a student, I was already interested. I did my first implant course as a student. So I've always been interested in dental implants, and it's just, it hasn't gotten better, it's gotten worse over time. So I'm still practicing, but I'm a GP with a practice limited to dental implants, mostly full arch. And then we run a group locally here with Dr. Hewish, and we've got various of our other partners that are here tonight as well. So, and then full disclosure on this, I'm a part owner with Parker in the dental lab here, owner in the dental offices, and we have Neodent that's sponsoring and supporting us tonight. So that obviously is going to influence me in some way, and you decide how. All right, so there are the disclosures. There's people that have supported and paid money for our different courses. We appreciate them, but at the end of the day, I try to only promote stuff that I would use myself, and I've also turned away a lot of people that have offered money that I don't believe in their products. So hopefully I can be somewhat objective. So tonight the topic is one that I think for me kind of came with experience in hard knocks, which is anterior implant aesthetics. How do we make those as predictable as possible, because they're high stakes? And then the other part of that is the theme of this whole series is digital workflows. How do we use digital to make things easier, make things better, make things faster, all the above. But I really think it comes down to a foundational knowledge first of what we're doing as it exists in an analog workflow, as it exists in a digital workflow. The biology doesn't change, right? It's going to be the same no matter what our workflow. So a fundamental understanding of kind of the basics, boring stuff first, and then we can launch into the fun and exciting stuff, which is all the digital workflows. So I think it all comes down to this. As dentists, I think that's part of our progression in practice, is to figure out how to diagnose the root causes instead of the symptoms. Chasing symptoms is something that I've done a lot of in implant complications, and if I can shorten that path for you guys, that's part of why my motivation to be here. So I think no matter what our discussion on implants is, it starts with the risk factors, right? Which is, first off, high level. How, when we do any sort of treatment, we're dependent on the patient's health, them to heal, and them to maintain that biology and that health over time. So if they're not healthy, our chances of success are right off the bat going to be lower. So managing the things that we know about, diabetes, smoking, any sort of uncontrolled disease that will affect their healing, really is what it comes down to. We know there's newer stuff too, like the vitamin D deficiency. There is a new study out showing a 4 times higher risk of implant failure with low vitamin D levels than a heavy smoker. So that's pretty significant. There's antidepressant, corollaries, and cholesterol corollaries. So there's all kinds of systemic stuff that we're just figuring out that we need to be aware of. And then what's the local health, right? What's the health in the mouth? If they've got raging perio disease, OHSU is right. We should treat that first. Right. But just figuring out, how healthy is this environment before we go and put implants in. And then functionally, what are we looking at? What are the forces going to be on this implant? Which that's a big part of what we'll talk about tonight. So I'm not going to belabor that right now. Wish this clicker was a little more effective. Huh. Do you mind hitting the space bar on that? Thanks. And then we can move to the actual site, right? Once we've talked about or thought about the global stuff, what does our site look like? What does our spacing look like prosthetically? Do we have hypereruption? Do we have tipping of a tooth? Again, that's a topic for tonight. And then this is one that I think gets underrated, is the soft tissue. You're like, oh, there's bone. Let's throw an implant in there. Well, if we don't have a good, stable, thick tissue around the implant, we're going to see in some of the studies we look at how that's not going to last. And then lastly, this is the one that I purposely put this lastly because as a new excited implantologist, we always jump to what does the CBCT show? How much bone do we have, right? And that is important, but we should work through this other stuff first, so we're looking at the full picture. Slide. Thank you. Okay, so nice Venn diagram here. We have function that we're trying to, as dentists dial, and we have aesthetics that the patients really care about. These are the two things that patients care about. So we're looking for this happy medium that satisfies both of those, right? And to get that on day one is not that big of a deal, but the issue comes in being able to do that. Oh, now it's, sorry, I'm really struggling here. Can I try, this is the receiver right here. I wonder if I put it like, there we go. Yeah, it was that. Okay, so our functional goals, right? We need to have biocompatible materials that are going to play nice in the mouth. We need things to look good with how the soft tissues are framed. It needs to interact with the rest of the occlusal scheme appropriately, with forces, with being, functioning like a tooth for the patient. And we need to use materials that are going to hold up over time. And then our aesthetic goals are that it looks like a tooth, essentially is what it comes down to, right? We want it to look as much like a tooth, and that includes shape, translucency, color, all that kind of stuff. But for this stuff to last, we have to consider this, right? Because if we're not putting a screw into a block of wood, we're putting an implant in a living organism, right? The bone is a living organism that's going to change over time. The soft tissue, same thing. So if we don't respect and understand the biology, what we put in today is not going to look good necessarily in 6 months or a year or 12 recall cycles down the road. We're going to have all kinds of stuff happen to us. And if you're like me and you just kind of get into it and don't fully understand all this, then it's really frustrating. You're like, why was this one okay and this one's not? And that's kind of part of the point of tonight is to talk about those things. So I like to think of our thing in multiple zones here, right? We've got the part of the implant that sits in the bone. We've got this transitional zone. And then we've got the part that the patient cares about, right? The patient doesn't want an implant, they want a tooth, right? So how do each of these zones react when it comes to the biology? So let's talk first about the implant abutment interface. So one reason that Neodent is sponsoring here tonight, quick little plug for them is they have a really, really good connection. It's a good connection from a functional point of view, forces and stresses. It does a lot better in oblique loading than a lot of the other systems because it's a Morse taper. And it's a really good connection from a biological point of view because it's clean. It's there's a that Morse taper creates a tight junction, so you don't get bacterial pumping in it like you do with some of the other connection styles. So that allows, it helps with the forces, and it also helps with the biology. All right, and then we have the abutment tissue interface, which is that emergence like from the bone level to the intraoral environment, right? So I have crossed out here keratinized tissue. This is semantics here. You guys are in the Perio Club? So what's the difference between attached functional tissue and keratinized tissue?
That's a really good question for I don't know.
You're not in the Perio Club anymore. So this is, that's the great thing about teaching is you kind of get raked over the coals sometimes and you learn stuff. So this slide used to say keratinized tissue, and someone's like, well, what about a cadaver grafted tissue? And it's, histologically not keratinized. I'm like, yeah, I don't really care. Like, the research doesn't really care. It's if the tissue is bound tightly to the bone and it's non-movable, you're going to get a good outcome. All right, so that's what we're talking about. Attached functional tissue means I don't care if histologically it's keratinized because it was taken from a free gingival autograft, or you opened a cadaver tissue graft product and used that. As long as you thicken the tissue and it's attached to bone, it's going to work, right? But there's a cool study we'll look at that talks about the relationship of the horizontal and vertical component, because I used to think of this in only the horizontal component. How much width, like when you're checking to see if you need to do a graft on a natural tooth, how much, what's the measurement with the probe of attached tissue. But there's also a vertical component to it, and in implantology it's really important to understand that relationship. And then in this interface, the materials we use are really important, right? Because there's certain stuff that the gums really don't like resins. Resins are pretty cytotoxic, and that's just going to create this ongoing inflammatory response, which we know leads to recession, right? So what does play well here of our restorative materials, you'll notice back there we use a lot of zirconia and a lot of titanium, is because that's what the research shows works well in that interface. It's biologically compatible, and there's probably new materials that aren't invented yet that will be better, but in 2023 that's what seems to work really well, so that's what we use. And then there's other stuff that's kind of somewhere between those materials that we'll use in certain instances. All right, and then lastly, the part that the patient cares about, right, the tooth part. So again, our goals are we're looking for something that isn't going to retain plaque. It's non-porous. Some of the older ceramics, stacked ceramics, were very porous, and they'd soak up plaque like a sponge. And you have these studies showing class 2 decay next to one of those ceramic crowns. So by using, again, zirconia or like Emax, these materials that are a lot tighter structure, we can avoid that. And then, of course, just our good old-fashioned prosthodontic rules, right, about we want good, just for implants, we want light contact in MI, and in excursives, we want it to miss. So we're not side-loading our implants. And then the other part that we'll look at is the contour as it emerges from the gingiva, keeping that less than 30 degrees so that we don't experience problems with tissue recession. All right, so what are our options? We've talked about kind of the overarching goals, but what tools do we have in the toolbox when we start looking at this, right? So we'll kind of take a tour through history of what's traditionally been used and kind of where we're at, my philosophy. And the other thing is what I do isn't necessarily right. It's just based on my experience, based on the research I've seen, and there's a lot of different ways to do this. So I don't want anybody to feel like they have to do it exactly like I do. Oh, that was it's my girls at a course. All right, so this is a kind of a split slide showing, has anyone ever used stock abutments with implants? I'll raise my hand. I did once. I'm not ashamed of it. I should be. So what was the problem with stock abutments? What happens? Yeah, what happens when you cement?
On a fence post.
Yeah, there's that. There's the the restorative profiles. This is a big problem, right? You get your nice glass ionomer dual cure, or I mean your resin dual cure cement, and squeegee it down in there. How's that gonna go? Yeah, there's a big problem with pushing stuff down into the sulcus that doesn't belong there, right? So then somebody smarter than me was like, well, what if we custom make every abutment and bring that up right, tuck it right below, so that when we cement that on, this clicker sucks. There we go. It pushes, path of least resistance, it pushes out here. So, that was a big improvement. And I think, there are a lot of people who still uses custom abutments regularly. Yeah. We do every now and again, right? A lot of people use them, and it's a good restoration, right? But then, we're talking about digital dentistry tonight, right? Oh, gosh. Okay, then somebody was like, okay, well, what if I'm pretty lazy? I don't know about you guys, but I'm pretty lazy. So why would I do this in the mouth if I could have my lab do it for me, right? So then they said, well, let's take this custom abutment, we'll glue it together in the lab with the crown, and then we'll make a hole. So that was the screw-mented restoration, which is also a good restoration. You got polished titanium here, you've got zirconia, Emax, whatever, for your crown. It's a good biocompatible restoration. You get nice emergence with it. We're also talking about anterior aesthetics today, though. What happens if you get 0.5 millimeter of recession there and it's number 8 and they've got a high smile line and thin biotype?
It's a fail.
Aesthetic fail, right? They're going to smile and show metal, and then they're not going to be happy with you. So the tie base. Who remembers, does anyone know what the first tie base was? The origin story for the tie base? Any CEREC users? Yeah, so it was CEREC, right? CEREC came up with Sirona came up with the tie base concept, which, how tall were the walls on the original tie base?
I don't remember. I never did any of them.
Non-existent. they were like a millimeter, maybe a millimeter tall, and their whole thing was, it's when they did all the top hat preps, the whole thing was, oh, this is going to be adhesive bonding. We don't need retentive form. So tie bases got a bad rap because the early ones the crowns all busted off because there was no, the basic thing we learned in dental school, right? Retention form and wall height and all that. So eventually they learned their lesson and they fixed the wall height. And now I think, used appropriately, the tie base is a great restoration for implants because we have, especially in the anterior zone, because we've now taken with digital dentistry that custom profile and designed it and milled it into the zirconia. The tie base component is sitting down there and is stock, but we've now taken what was milled in titanium is now milled in zirconia, making that nice emergence. And then if we do get a little bit of recession, it's white, right? We don't show metal. And in a thin biotype, we don't get that transmission of the gray through the tissue. So I think there's a lot of advantages to tie base for that reason. And then I love a screw retain restoration. It's easier to put in because remember I'm lazy, and it's retrievable if you have issues down the road, right? So what about anterior cases and tie bases? Anybody ever had this where they've just got that maxillary flare, their bones sticking straight out, and you go and you plan your implant diligently, you use a guide, but there's just no way to get that long axis on the lingual side of the crown, right? Just because of the anatomy, then the remaining bone. So there's the development of the angulated screw channel, which will, on the hands-on part, we'll mess around with those a little bit, so you guys get familiar with that. But all we're doing is taking that screw channel and digitally kicking it backwards, right? And then using a screw, ball and socket screw system that we can screw that screw in off angle. And that allows us kind of the best of both worlds. It allows us to put the access where we want it, and it allows us to still screw retain, which I think is more important in the anterior than anywhere else in the mouth. Okay, so this is the Neodent system, obviously, Neodent sponsored. But this is theirs. Most systems at this point have an angulated screw channel solution, but it's just using a different driver that allows us to angle it like that. Okay, and then there's another example of that, and then versus the straight, right? Makes sense to everybody? Any questions on the ASCs? Yeah, it's pretty straightforward. But it's a great, I mean, how many of those do you think we do? We do a lot, right? Which is just sometimes the anatomy just does not allow for screw retention without it.
5% of our anteriors are angled properly.
Yeah. All right, so this is, again, we'll play with these here in a second, so just a couple slides on. So Neodent has this continual torque wrench. I feel like when people first pick up the system, something about it coming apart is really confusing. So we can go over that. It's pretty easy once you get the hang of it. But I like systems that have these continuous torque wrenches. And then the other thing I like about the Neodent system is the simplicity. Like, this is a restorative driver. It's also the surgical driver. The surgical and restorative kits are just pretty simple. I think the less parts, the better when it comes to that kind of thing, as far as keeping track of everything and sterilizing it and buying replacements. All right. Any questions so far on that? So I have this section here on analog implant impressions, open tray versus closed tray. Would that be helpful for anybody, or do we want to skip over that? Skip it. Okay, I thought that might be the consensus. So we'll go ahead and skip that. Just hold this up. Because there's more stuff that we want to get to. It was a lot of work to make those slides. Shuck. All those years ago. This might be useful for somebody. We'll start here. Okay, so the whole takeaway for me was I use closed tray most of the time because it's easier. We only used open tray for like bridges and splinted things. So if you do have an analog case and you don't have a scanner, this is how we used to do it to make things quick and easy. We'd take old burrs, sterilize them, and then just hit them with some flowable composite and splint that way, and then use stock trays. It just saves time, saves money. But with scanning, most of the stuff has gone by the wayside for us. And then the point of this slide was just, in our practice, we're pretty utilitarian, where you need a really good impression around, and you need to pick up the adjacents really well. But if you've got a void in the palate, who cares, right? Or maybe you're a better dentist than me, but for me, that's going to be a good outcome because we have the data where we need it. And if we don't have it where it's not necessary, who cares? All right, here's another, splinted for teeth that are close. And then this was just a cautionary tale from the lab. Know what your parts are. This was a case that a doc, he's somewhere up in Washington. We got the case on the third try where nobody else could figure it out. And they're like, well, you guys know a lot about Neodent. We're going to send it to you. So this guy had taken a triple tray. He used an open tray impression coping with his triple tray. And he kept getting this, and this was his placement. He kept getting this case back, and he's like, I don't know, it's rotated. It's not the same on my model. So I was like, okay, send me everything you have. Let me look at it. And I was like, do me a favor, snap an alginate of your abutment in the mouth, and then send me everything. So I get it all, and I'm like, as soon as I get it, I'm like, dude, used an open tray impression coping. So you got the lab had a 50-50 shot, right? And maybe they got lucky on the last one, but on this one they got unlucky. So we rotated it, we remade the abutment, and everything worked out. But I mean, the takeaway was if he would have just used a closed tray impression coping and taken an extra minute maybe to use a stock tray instead of that thing, then it all would have worked out. But so we got there eventually, and that we did the best we could. with the the angle and the placement of that implant. But we sent it back with the right component. So next time he would, and he went back to his other lab. We never heard from him again. So it was all good. All right. So, but this is what. Who in here has a scanner in office? So almost everybody. Great. So yeah, this is where we're gonna spend most of our time is on the digital stuff. So there are a lot of advantages to it. A big one is being able to outsource more of it to my team. The accuracy of it. But there are a couple of things to be aware of. Errors that we see with digital impression scanning. So that's part of why we're here, right? And if I was just to list the top ones off my head, one would be taking a scan and the scan body is not completely seated. So we see that fairly common. And when we get info, we'll go through a design workflow later. When we get info in the lab, there's nothing, we can't change it or modify it like we can analog data or actual models. There's no confirmation or anything we can do. It's what we see is what we get. We match the scan body to exactly what we're given, and we design that. If that data is bad coming in, it's not going to fit. So, as long as we pick the right scan body file and we match to that data set, and even our model that's 3D printed is going to be based all on that, right? So it might look really good on our model, it looks good in design, and then you go to put it in, and the thing is 2 millimeters tall, and you're like, man, this lab sucks. How did they get that far off? Well, it's because that hex hung up and it didn't seat all the way. So the whole scan is 2 millimeters higher than in reality, and everything shifted, So digital is usually really, really accurate, or it's way off, right? It's not like analog cases where you got to grind it in a little bit. It's usually really accurate as long as the data is good. So that'd be no, go ahead.
Do you see that implant kind of being super gingival when you're going through the process?
Well, it depends, because a lot of the popular systems are subgingival placement, right? So it's hard for us to know. Yeah, and there are some. So like if we have a tissue level, like it's going to be obvious, but we don't do a lot of. Yeah, we don't see a lot of tissue levels anymore. That's not as popular as it used to be. Like the Straumann ITI used to be a super popular one, and there's still some of them, but most of the stuff is, systems that are designed to be placed subcrestal. So if we see an implant that's 3 millimeters subcrestal, we're like, it's within the realm of, if we see something really weird, like it looks like it's 6 millimeters deep or it's sticking out of the gingiva, then we're going to call and ask questions. But there's also, if it's 1 millimeter or 2 millimeters off, could be within the range and looks good on the model and everything checks out, and we select a 3 millimeter tall tie base, and then you go to put it in the mouth and it's sticking out of the gums 2 millimeters, so that's where it's, and what I recommend there is you use a tie base, or when you do that, especially if you have a team that you work with and they're helping you in the process, just get a quick check film. Make sure that it's seated radiographically before you scan. And that's how you can mitigate that. The next one with the scans is a scan where the scan body is not completely picked up. You would think in 2023 that the software would have a library of the scan flags and we'd be able to match. But the software is, both 3Shape and ExoCAD, is designed to do a best surface match. So if there's a hole in the scan body or a corner missing on your scan, the software usually will close that, depending on your scanner, but most of them will close that hole. But when it goes to do the surface match in the software, it'll move it slightly because it's trying to match that corner that's missing, and the STL in the software, the design software, is perfect. So if you're missing corners or it's rounded over, it'll kick it down a little bit or kick it sideways, and then you're going to be just slight. If it's a single unit, it probably will still work, but you're like, oh, why is this contact tight and this one's loose? That would be a symptom of that.
What were you just talking about? Like that last bit where you were talking about how things like rounded off and stuff?
Yeah, so this is your scan body, right? Here in this picture that's going to get scanned. So this one has nice square edges on it. Most of them have some sort of geometry. So if you scan, so in the software, what it does is, you'll see the slide here later in the lecture, but you'll have the STL that's perfect in the software, and then you'll have your scan, and the software is going to try to match the surface of its perfect example to the scan. So if you have like a rounded corner here and it's sharp here, instead of it perfectly lining up, it'll kick it in just a little bit to try to match to that surface. And it'll just be slight. So your implant position in the design is going to be slightly off of what it is in reality. And it might be minuscule enough that it doesn't matter, or it could be enough that it does cause an issue.
So is there going to be a discrepancy because your scan body's been damaged, or are you saying just because maybe
you didn't capture it? Yeah, you didn't capture it 100%. Now, if you're using peak scan bodies and it's been used 100 times, and yeah, then get rid of that scan body. But most of the time, it's something doesn't get captured. Along with that, the other thing is, especially when it's really tight, the interproximals of the adjacents don't get captured, right? So there's a hole, and sometimes it is really hard. You know, as a clinician, I know trying to get in is difficult sometimes. Most of the scanners have a workflow, though, that you can scan everything and then add the scan body and scan again. So if you have, you know, like a lower anterior that's really tight, you can do it in a two-stage scan. So, you know, making sure you capture, because again, the same thing, the software is going to close those holes. So if, you know, it's missing an adjacent contact, the software will just chop it off, and it's going to do its best guess. But that, again, might be a contact that's too tight or contact that's too loose. You know, but if we design to the data we're given, and it doesn't represent reality, then that might be an issue.
How much of the axis do you have to be able to scan? Like, so the inside?
The inside,
that
none.
doesn't matter?
Yeah, that part doesn't matter. What matters is the sides, getting the sides really well, and then getting a clear of the top. The interior data doesn't matter.
Right, most of the time what you're getting is a scan. Just a scan body, scan and then a posing and a bite. That's it?
Yeah.
It's a lab?
Yeah.
Okay.
Yeah. So it's, you know, like I said, digital is awesome, and it's great clinically, and it's on the lab side too. It's a great workflow. That's there aren't all the steps of analog where stuff can get off little by little. So it's awesome there. But if that data doesn't come in accurate, then we have no recourse, right? So,
Sorry.
yeah, question. No, you're
Do
good.
you ever request like just an additional scan with no scan body? Because it would be fairly easy to get that.
Yeah. So I mean.
Stitch it, or am I getting ahead?
No, you're not, and that's a great question. And sometimes we do that. So in full arch, a lot of times our designers will be like, you know, they've done enough cases that they're like, something's off, and they'll call the office and say, hey, look, you know, before we make this expensive thing, like, do you guys want to verify this? Do you want to send it? And you know, then the office will say, no, we know it's perfect. Press forward. Most of the time they say, oh yeah, well, you know, if you're seeing that, we probably do need to. So. In the full arch, more so probably than single units.
Okay.
But another question?
Might be a stupid question. Just never understood this, but why all this is doing is really just like mapping out where things are, right? So why can't we just have a healing abutment that has like a letter or something, and then you can just scan the healing abutment, and because all it is matching STL into a space.
Right.
So why do we need a whole separate thing?
So Encode, has anybody ever used Encode? It was Biomet 3i. That was their idea. That was one of the original scan bodies. It was the healing abutment. It had a little bit of geometry on the lid, and it worked pretty well. The only issue you'll see later when we go through the design slides, the more surface area, that's more likely to get higher accuracy, because if you have a small little healing abutment and you're missing any of that, the chances of it getting off angle are higher. So, well, I think when you see it visually, it'll make more sense. Let's click through here. We didn't get very far. So you all have scanners. You know how to scan. You know, it's funny. Like just a few years ago, people were like, "Wait, what? How does that work?" And you know, it's crazy how much scanning has changed dentistry in just a couple of years. So we'll skip through this. And then the point on this was on the lab side. You know, even when we get analog stuff like this, let's click here. Even when we get analog stuff, all we're doing on the lab is creating a model so we can scan it, right? So it just makes so much sense to just use I/O scanners, because we're going to skip all this stuff, which is extra work on the lab side, extra chance of stuff being off. even the impression material and dealing with all that. So, we can go through all this and create this, or, then we end up doing what we could just do directly in the mouth, right? So, come on. So, why not just skip straight to this, right? We just scan it IO, we print a model, and then we have, something we can adjust on and check everything. But again, if this data is bad, our whole model is going to be bad, right? So getting that scan body seated correctly and getting a good scan of it is incredibly important. And this is the other thing that's cool to me. This was, I think this was printed on a Form 2 printer, which, like 2-3 years ago, this was pre-COVID, this was like state-of-the-art stuff. I look at this now and it just looks so, it looks like a dot matrix printer compared to the quality of the stuff that our 3D printers are kicking out now. So it's a really exciting time to be involved in dentistry and involved on the lab side too.
I have a question.
Yeah.
How do you get the analog and the 3D printed model?
So most of them snap in. So it has a little channel, and then a lot of so it comes with the library file from the manufacturer. A lot of them have like a little click thing where it'll actually come down and click into place.
So are you printing the model and then putting the analog?
Yeah, you press fit.
Oh.
Yeah. It's also, thank you for that question, because it made me think of one other thing. One other issue with scan bodies that we run into here at the dental lab is, you were showing that PLX case earlier. So a model of that Straumann uses currently is, if you call up the rep, they'll be like, oh yeah, our scan body's super affordable. It's like $20, $25, which you're like, wait, a Straumann? How could that be that cheap, right? Well, it's because their tie base is like $200, right? So, and they know if you scan with their scan body, the Straumann scan body, then as a lab, we're locked into using that OEM part, which we're happy to do, but it's always that awkward call, like, hey, we try to keep our prices really reasonable in the lab, but if we charge our normal price and pay $200 for tie base, we're going to lose money on the case. So we have to make that call and say, hey, do you want us to use this scan and OEM parts and upcharge you $150 to make all the numbers work, or do you want to rescan with an aftermarket scan body? Right. So just be aware of that. As a lab, or any lab, once it's scanned with a proprietary scan body, we're locked into that workflow and those parts. So if you scan with a Straumann brand scan body or a Nobel's brand scan body, and some of the companies, you're locked into using their milling center too. So it can create a lot longer lead time for us, and it can create or add a lot of cost to the lab case. So my recommendation, you can do whatever you want. And if you want to stick with that, that's fine. You should just know that. But our recommendation, what we do with our offices, is Medentica is a German-made abutment company, aftermarket company. It's actually owned by Straumann. It's really good stuff. Their tolerances are actually tighter than a lot of the OEM stuff. So, do you guys still offer those scan bodies?
Yeah. So.
Yeah. Do you want to talk about that?
If you're under my reps in the West Coast, so it might not be the same in the Central or the East, but I always give the doctor the scan body for free, and then you can use the Medentica parts, which save you money. They have a lifetime warranty. They are German engineered, so the tolerances are tighter on the microgap between the abutment and the implant, so it's better for the patient, really long term.
Yeah, so that's what we have recommended as a lab is, get the Medentica scan bodies, use those, and then we can use those Medentica parts we can get for usually half as much as the OEM, and we can keep the lab costs lower.
So you don't have to make compromise to your patient's care.
Yeah, so there's other stuff, we could save more money by buying stuff off eBay, but we're not going to do that, right? It's got to be legit stuff, but there's different workflows.
If you're not doing impressions for, say, Straumann that often, because they're the ones that kind of lock you in,
Mm-hmm.
if I do an analog impression, are you guys on your digital workflow? Are you guys locked in?
No, that's fine.
So you're still able to overcome.
Yeah, because what we're going to do is we're going to
You're still gonna-
pour that model up, and then we'll take a Medentica scan body in lab, screw it in, and then we've got open workflow. So yeah, if we've got analog stuff, then we're fine. It's only if we're getting straight digital data. Right? Make sense? Cool. Yeah, I think that's all the pitfalls on the. But otherwise, I mean, it's just so nice to use the IO scans for everybody, for the lab, for you. All right. Are we good to keep moving? Cool. If I'm losing anybody, you want a break, or we need to do something more exciting, let me know. Now I wanted to get back to kind of the pros, and I want to look at a couple studies. I'm going to try not to bore everybody, but I want you to know that this is stuff that's borne by the research, not just things I'm making up as a GP that you may or may not have ever met before. So let's talk a little bit about the prosthetics. Because the prosthetics are, biologically, they're the same for the posterior, for the anterior. I call this anterior prosthetics, though, because it's higher stakes, right? It's where we really need to be aware of contours and how the biology is going to respond. Whereas in the back, if we get a little recession, but it's still functional, probably not as big of a deal. All right? So we talked about this stuff already. So now we're going to come back to it. So let's play a little game here. We've got 2 implant crowns, and our red arrow here is the force. So we're putting a complete side load on both these implant crowns. Where are we going to have the most torque? At this red dot or at this red dot? Use your pointy finger to tell me which side. Okay, only half the room is voting. Okay, yeah, good, right? Longer lever arm here. So if we have a taller crown, we're going to get more torque, right? It's pretty basic concept. So what do we do about that? How can we mitigate that?
Increase the height of the base.
Yeah, so should I place my implant 3 millimeters out of bone? I'm being a jerk. It's, sometimes we can't. I mean, you could try to graft. Sometimes in the posterior mandible, it's just not going to work, right? Sometimes we have to have a tall crown, but we can still do things to help. All right, let's play one more here. This is kind of covered here, but there's an arrow here on this cusp tip. Which one of these is going to generate more torque? This one, this one. Oh yeah, you guys are on tonight. I like this. Okay, so obviously the wider occlusal table, right, is going to, and does that matter? Sometimes it does, sometimes it doesn't, right? There's a lot of factors. What's their bite force? What's their occlusal scheme? How many adjacent teeth are helping support the load? All kinds of things. But we just want to think about, the crown height, the occlusal table is going to affect that force distribution. And then, what about this one? Can you toggle that picture-in-picture down? So it's not in the way there. Okay, so here, hopefully that's a little easier to see. Where are we going to generate more force? This one or this one? And why is that, Dan?
Higher incline plane as you hit is going to generate more friction, so it's going to.
Yeah. Yeah, exactly, right? We've got a direct force for that lever, right, as opposed to kind of a glancing blow, right? So back to that first one where I said, what can we do about that tall crown? That's one thing we can do, is flatten our cusps, right? So when they do go to an excursive, they're not going to be able to generate as much force on that tall crown. The other thing we can do is, we might splint, and then narrowing the occlusal table, right? So those are all things that we can do prosthetically to mitigate compromised situations. Okay, now, before we get into this, what is an acceptable crown to implant ratio?
We're talking bicon.
Right. Okay. Again,
Anything goes, buddy.
again, trick question. The research shows that implants aren't teeth, right? So in teeth, we're worried about our crown to root ratio. In implants, the research shows it has to do with crown height and the the implant only sees stress in the top 5 millimeters of the implant. So as long as you've got an implant that's longer than 5 millimeters, all that matters is surface area and height of the crown and your connection. But it's not, it doesn't translate from teeth to implants. So get that idea, it's a mishism that we all grew up on, but get that idea out of your head that we have a crown to implant ratio. It has more to do with the prosthetic height of the crown, your connection, and your bone contact. How much surface area of the implant is in contact. All right, so here we go. 10, 12, and 14 millimeter tall crowns. And this is finite element analysis, which is really fun to look at. So we have axial, long axis loading, and then we got oblique off axis loading. So 200 straight axial, straight down the crowns, and then 100 newtons at a 45-degree angle, kind of similar to those picture slides we just showed. So let's look at this. Okay, so these are the axial loads. Do you see much, and this is an old external hex, right? Do you see much difference between these? Would you expect to see much difference? Not really, right? If you're coming right down the crown, you don't have any lever arm on that. So this all makes sense so far. I don't know.
Oh, it just,
It slept?
there,
It's back. Okay, good. The electronics always stress me out. It's like this goes down. Again, it's great, but if this goes down, I'm hosed, right? Okay, so now we've got oblique force on here. What do we see here?
The same.
Yeah, so as this crown gets taller, the red area here is the high stress, right? So this is a close-up of the screw. So we've got a lot more strain on that tall one, right? And what does this translate to over lots and lots of cycles? Broken screw, deformed abutment, those kind of prosthetic nightmares that we all deal with if we're in the game long enough. So, this all makes sense based on what we've already talked about, right? So the taller crowns are going to experience more torque. They're going to experience more strain, and if that gets outside of the strength of the system, then we're going to have breakage. So somebody mentioned, we'll do this first. So this is another study, kind of same idea, FEA analysis, but this study is different in that we've got 3 different connections, right? So here we've got, it looks like a tissue level ITI Strawman, we've got an external hex, and then we've got, I think this is a Nobel active or conical there. So you can see the connection does matter, right? We see the amount of stress, concentrated stress on that external hex. And then we see here, because of the way that connection comes together, there's more surface area to transmit that force. So we see lower stress, lower point stress loading in that example. So I don't have this slide for Neodent, but I imagine it's going to be similar to this, that more tapered and not like these others. Okay, so this was the conclusion, right? So they say dental implants with a convergent platform switching collar express better stress distributions than straight or divergent collars. I think they got the conclusion wrong, personally. I think it has more to do with the geometry of the connection, not the fact that it's platform switched. But I think that's what they're trying to get at in different words. So yeah, somebody mentioned Bicon. Right, so if we're talking about crown to implant ratio, how's the crown to implant ratio here? Really good. Right, but what happened? That's not good, right? And then we got these Bicons that you're like, just look dumb. They're so tall, and you got 4 years, 17 years. And they work because you've got this really strong connection, right? And it stays together, and there's this short, squatty, wide implant, but it's got a lot of surface area, and we know that stress and strain we don't see more than 5 millimeters below the crest anyway. So the body and the system doesn't know. I mean, as far as the implant system, it doesn't know if it's 5 millimeters long or 50. As long as it has enough osseointegration that it doesn't come loose, and it's got a strong connection here, it's going to be fine.
And as old as that design is, it was still platform switch too.
Right. It's probably the original platform switch. And you got to have your hammer handy too.
That's the guy that designed it.
Yeah.
You're-
Yeah, they're still, I mean, they're based out of Boston, right?
Bicon,
Yeah.
Originally Tom Driscoll.
Was he was from the Pacific Northwest, wasn't he?
I don't remember that part.
I think there's history here with Bicon, but yeah, I don't remember either. Okay, so here's, again, a few different systems. This is the Neodent GM that we've been talking about. Anybody recognize this? Yeah? What? Trilobe, the beloved trilobe. Has anyone ever had a prosthetic issue with a trilobe? No? As long as you use wide diameter implants, it's okay. The problem is these narrow diameters, right? These are infamous for problems because you don't have to be a rocket scientist, right, to know where that thing's going to break. You have this stress loading on the thin walls right there, and that's the bad rap they get, is that fracture at the connection. And this is probably also a treatment planning issue of, is that an adequate implant with that connection for that site? Who knows? There's a lot that goes into that. Obviously, it was inadequate in this case, right?
They were very popular implants.
Yeah, they were a very popular implant because they're restoratively very easy compared to the other options at the time, right? There's only 3, especially compared to like a Synocta with 8 possibilities, right? Three possibilities. But when you look at the point of that slide is looking at thinking about the stress and the strain and those components of the system. All right, so now let's talk about a little bit more about this concept, the crown to implant ratio. So here's a bunch of systematic reviews. Go ahead and pull your phone out so you can read all these later. I don't see any phones, weird. All right, so lucky for you, we did all the dirty work. These are kind of the top level conclusions that I think have clinical applications from those systematic reviews. The one we've already talked about, right? Implants are not teeth. These studies show that the stress and strain are applicable to the most coronal 5 millimeters of the implant. The stability is a function of the bone to implant contact, how much osseointegration there is on the surface area of the implant. So you can have a short implant that's wide, assuming that you have plenty of bone around it, you're not out of the bone, is going to be very stable, right? Because you got a lot of bone to implant contact. Or you can have a very skinny, very long implant with a similar bone to implant contact, assuming the prosthetic connection is robust enough, it's going to perform well also. So there's a lot of ways to go to get to the same result. And then the other takeaway consistently across these articles is somewhere around 15 millimeters seems to be the magic number. If a crown's shorter than 15 millimeters, they generally do pretty well with a variety of different connections. If they're taller than 15 millimeters, consistently seem to have problems, right? With the exception of some of these better connections. Most of this research is done. To have a systematic review, it's going to be on older connections, right? To have that much data. So a lot of it's external hexes or internal hex data, not any sort of Morse taper data, right? So that being said, if you have a superior connection and you still observe these things, you should do pretty well in general. And then the other was we talked about already on that one study. If you have a deep conical or a Morse taper connection, you may have a better transmission of force, especially in off-axis loading, than like an external hex or some of the older connection styles. Does that all make sense? Cool. All right, so now let's change gears a little bit. We've talked pretty heavy on the prosthetics and like the mechanics. So let's talk more about how the body reacts to what we're doing in this abutment interface zone. All right, so we're going to look at a couple of studies again here, and again, just gloss over them for you, but talk about the conclusions, right? So this is abutment height versus bone loss in these next couple studies. So the conclusion here was, says the study suggests that implants with taller prosthetic abutment shows less mean bone loss with the abutment height recommended to not exceed 4 millimeters. So what they're showing here is if you have an implant that's placed and you have like only 1 or 2 millimeters of abutment height, we consistently see bone loss with those situations. If you have a longer one, they're saying in the range, so the taller, not to exceed 4 millimeters. So having a taller abutment, more running room in the tissue, is going to do better, fare better over time, be more stable over time, which again conceptually makes sense to me. You have more area of seal around the abutment. You should be able to keep the connection clean and not experience biological width invasion and bone remodeling and all of that. So let's look at another one. This is on the same topic, different study. So this one says the results suggest the shorter the abutment height, the greater the marginal bone loss in cement retained prostheses. Abutment height showed a greater influence in platform switch than in non-platform switched implants. So that again makes sense. If we're not platform switching, it doesn't matter how deep we place the implant, we're going to have biological width problems. But assuming we're using a platform switched implant, which I think everybody should be in 2023, if we place the implants deeper and we have a longer abutment, they do better. It's kind of the same result, said differently in the last study. Okay, and then one more. The use of long abutments in combination with subcrestal implant position in sites with thin mucosa led to lower interproximal bone loss in comparison with the use of short abutments. So 3 different studies, same conclusion, right? Having a little taller abutment, especially in thin mucosa situations, we're going to have more stability of the soft tissue over time. So has anybody read Zero Bone Loss Concepts, book by Linkovis? All right, Dan. Nerding out. I like it. So the biggest takeaway, it's a great book, but the biggest takeaway for me is this. What's the most common site that needs an implant? Lower for smaller. What does the tissue look like in a lower for smaller site when they've been missing it for 15 years? Yeah, there may be no KT to begin with. And if they do have keratinized tissue, how thick is it? Not thick at all, right? Usually like a mil. It looks like this usually, right? Yeah, toilet paper. Perfect. So, well-intentioned to me, beginning my implant journey, I placed a lot of lower for smallers because that's the tooth that people are missing. And what happens when I place a bone level implant there and restore it? Pat myself on the back. What happens 6 recall cycles later, 3, 4, 5 years later? It's just that annoying marginal bone loss. Is it still functional? It still works? Yeah. It's still, patient's still happy, but for us it's just annoying, right? And for me it was like not understanding why is this happening? And why does it happen sometimes and not other times? And then, you go back and you dive into the research, you're like, oh, it's stupid easy. It makes a lot of sense. But, not knowing what you don't know was what got me in trouble. So Linkovis's whole thing is, what this whole thing comes down to is you need like 3 millimeters of tissue for this running room, right? And that tissue, it could be in soft tissue or it could be in hard tissue. So if you have an implant that's designed to be placed subcrestally and you have room to the IA in this situation, you could place this implant 2 millimeters subcrestal and restore to here, assuming this is a keratinized tissue, restore to this, and this is going to be a stable situation. Or you don't have the room, or you're using a system that needs to be placed crestally, augment the tissue first, right? And he's big into cadaver stuff. You could use a connective tissue graft. You could use, I don't know why you would, but you could use a free gingival graft if you wanted. I guess if you got a real narrow zone and you're trying to widen it. But using something to thicken that soft tissue first, you're going to get a lot more stable outcome, because then again you've created the tissue tunnel, right, of 3 millimeters or greater, which lines up with those other research papers we just looked at. So,
Can you do the soft tissue augmentation at the same time the implant, or do you do stage though?
Yeah, you can do it a lot of different ways, right? You could do it before your implant surgery as a preparatory thing. You could place the implant and you could augment tissue at the time of placement. You could do it before you restore. There's a lot of different ways you do it. But what I would recommend from a patient management perspective, that it's all, you don't talk about that when you go to restore. You talk about it before you start, right? It's all bundled into the treatment plan. because otherwise it's probably going to end up being like a free add-on.
Yeah.
If you're like me, you're pushover and you just want to avoid conflict. But if you tell them like, hey, we're going to do this, and you know, for us to do this right, it's going to include a soft tissue graft, and they know about it all up front, they sign off on that financial plan, and it's all paid up front, then, you know, then you could do it at.
Could you potentially do it at the same with like an immediate? Because I would imagine if you do like a CCG, that it's going to affect the. I mean, you're taking a blood source because you have to, you know, like you have to flat it.
Yeah. Yeah, so what I would do, if it needs that, I would bury it, and then I would do it around uncovery. Do your grafting then. Some people like to do it before. I don't like doing that. I don't like doing the soft tissue stuff first and then placing the implant, because sometimes you get tissue scarring and it makes it harder to manipulate the tissue, or if things don't heal as expected and you have to come and redo it. So I like to do it toward restoration time. But you know, there's a lot of different ways to do it. Okay, so here's another one, right? You guys getting bored of studies yet? So it says, within limitation of the study, concluded that the use of long abutments, internal connection, placed at the time of surgery in combination with subcrestal implant position led to greater interproximal peri-implant bone preservation in comparison with the use of short abutments. So same thing. Tall abutments do better, less bone loss. Okay, so what are our takeaways from all those studies? Right, in case you're sleeping, as long as we're using a platform switch system, a longer abutment means less bone loss. Bone loss is more pronounced when they have thin tissue and short abutments, which, like I said, is usually lower for smaller. And then to use a longer abutment, you can either augment the tissue, or you can place deep, or you can do a combo of those two things. Right, so it doesn't matter. Research shows it doesn't matter if it's running room in hard tissue or soft tissue. You just have to have running room. And my thought is that it's enough space to seal, right? If you've got really thin tissue, it's just not enough height to seal that abutment for the body to keep crap out of there. So if there's stuff getting down in there, you're going to have bone loss. All right, is that concept gelling well for everybody? Cool. All right, let's.
3 millimeters, like your hard rule of thumb.
It's an ideal, right? Do we violate? It's knowing the rule, right? So there might be situations or cases where I violate that rule, but I know that I'm violating it, and I'm going to mitigate that. You know, it's like the IA is right there. I don't have room to go deeper. The patient refuses grafting for whatever reason. Like, you know, we're going to say, hey, this is the ideal. This is what happens if you don't do that. But I also live in the real world, so I'm like, well, you know, we're gonna live with it, and it might work out, and it might not. Right?
So you're saying that normally biologic width is like 1.5 to 2.
Mm-hmm.
Why is it higher? Why is the need higher in the mandible, the lower mandible?
Well, it's just that tissue is generally thinner. So like if you place in the palate and you place crestal, you're observing this rule without even knowing it, right? Because that tissue is like 3 millimeters thick usually in the maxilla. So we usually don't have as much issues there, because naturally that palatal tissue is a lot thicker. In the posterior mandible, where it's really thin, 1 millimeter, that's where we run into this bone loss issue, because we're doing the same thing we do in the upper without understanding the biology, but instead of having 3 millimeters for running room, we have 1 millimeter. So it's mitigating, setting up the biology to work in our favor.
And then one more thing, the platform switch, that's just the conical, or what
Yeah, platform switch means that the abutment is smaller in diameter than the top of the implant. So the crestal portion of the implant, you know, traditionally with external hexes, it was a butt joint. It was the same width. Biomet 3i had the first platform switch implant, which was an accident.
What?
It was an accident.
Oh.
But then they said, oh, this is actually, they found out that it actually improved things. And all you're doing is you're taking that biological width, because what was the rule of thumb with the external hex? You're going to get how many threads of bone loss? 1 to 2, right? How many millimeters is 1 to 2 threads? 1.5 to 2. All right, our perio guys. What else is 1.5 to 2 millimeters in a biological system within the mouth? Biologic width. All right, so biologic width, right? All it is a body saying, hey, I need a little bit of space from this bacteria and stuff. I don't want all that bacteria on my bone, right? So it says I need this running room to seal stuff off. So same thing with an implant. So all a platform switch is doing is it's taking that from a butt joint where the crap's getting in there and the body says, hey, we're not getting too close to that, and that bone backs off a little bit. It moves it horizontally away, right? So even if it's a dirty connection, but it's got 1.5 millimeters horizontal, then the bone will stay there because it still has that little bit of buffer, right? But the Neodent or the Morse taper is better than a platform switch because you don't have a dirty connection there. So we've got x-rays in our practice of Neodents we placed 5 years ago where the bone has grown up and completely covered the connection because it sees that as clean. There's not bacterial pumping there. Which is pretty cool to see. All right, so does that answer that question? Yeah, good question. All right, so now we're going to switch gears a little bit. We're going to talk about abutment shape. Right? We talked a lot about the connection, the height. Now we're going to talk about shape. So this is another study that talks about 2 different abutment styles. So we've got a 45, a very wide abutment emergent profile, and then 15 degrees, pretty narrow. So this was a dog study where they placed these implants with these abutments, and then they sacrificed the dogs after 4 months and did histology. So what do you guys think? Which one of these did better for maintaining tissue? 15. Oh, interesting. Yes, that is what they concluded. So the flat and wide profile induced apical displacement of the peri-implant biological width and more bone loss. So in simple layman's terms that I understand, you smash the tissue out of the way, it's not going to stay put, right? So you use a big wide abutment and take the space where the tissue, because what keeps the tissue alive? Blood flow, right? If we blanch the tissue and force all the blood out of it, it's not going to fare well for very long, right?
I have a question about that. So
Yeah.
a lot of times when you're placing that, like an anterior, upper anterior, like central or something,
Mm-hmm.
and generally, I usually like to put like a temporary crown in there, and obviously trying to
Mm-hmm.
like push, like get some molding of the tissue. Is there? How would you go about? What's the best way of going about doing that to kind of create that emergence profile that you're looking for without creating a lot of damage?
I'm glad you asked. We got like 15 slides on that.
Oh, yeah.
Yeah, so buckle up.
All right.
All right. Yeah, we'll get to that. That's a great question. There we go. All right. So here's another study. Abutments with a concave profile allow for more connective tissue around them. The present prosthetic design demonstrates that the thickness of the buccal mucosa is of paramount importance for long-term success in implant dentistry, especially in the anterior. So again, this is saying you got to leave room for the soft tissue, right? Okay, so here's 2 more studies. We're just using photos. Just based on these pictures, this one or this one is going to do better. Correct. Okay, what about this one? This one or this one? Right? Do we see a commonality here? So it's this, what I call S-curve, right? Leaving space down deep, and then at the critical contour emerging to make it look like a tooth. So we're going to see that over and over. All right, so this is acting really weird. Okay, so you're asking what do we do to try to get. What I like to do is, I think it's just crazy to place an implant and then put a tin can abutment on it, let it heal around this tin can shape for 3 months, 4 months, and then go and say, okay, now I'm going to create a nice contour. So I like to, Neodent has nice anatomical healing abutment shapes. I like to use one-stage surgeries whenever possible. Put that on day 1 to allow that tissue to form ideally. And then we're just going to mimic that as we go to restore, right? As opposed to trying to redevelop that from nothing. And I've got some more slides that will show a little bit more in detail what we're looking for there.
Is telling the lab what size healing level you had in there, is that correlatable to anything?
It's helpful. Yeah, it is helpful. The other thing that's really helpful for anterior cases is getting that scan. So pull your temp out or your abutment out and get that scan right away of the tissue, because then we know where to put pressure and where not. If you wait for 5 minutes and everything collapses in, less helpful. But yeah, both those things are really helpful because that abutment is correlated to our tie base heights. And it's going to help us select a tie base.
So you
Right.
decide to take the impression without the abutment first as like.
Yeah, so most systems have an implant option where you can take the healing abutment out, scan your arch, or, your area, scan the soft tissue with nothing in there, and then go to the next screen, put the healing or put the scan body in, and scan that area again, and then it will give us a split file where we have one of the tissue and one of the scan body that we can toggle on and off, and that allows us to mold that emergence profile digitally really nicely. Okay, and then I promised that we'd talk a little bit about tissue height and thickness, right? This is a really cool study that was done where they they placed these implants, they waited for a year, and then they measured tissue height and thickness and the corollary between them. And this thing is just... Okay, so check this out. This study is awesome. Okay, so they used Megagen, I think any ridges, and so all implants were placed slightly subcrestal as recommended for the Megagen. So provisional screw retained prosthetic restoration was placed after 4 months from surgery and left for 12 months. So they left this thing in for an entire year. After 12 months, provisional restorations were removed and silicone precision impression was taken to make an individualized transfer to technique. So what they did is, you guys have probably all seen this or done this, where you preserve the shape of your, from all the work of making this custom temp. So they did this, they poured up models, and then they took measurements on these models using calipers. Okay. Can you just hit the space bar there, please? Thank you. So this is the takeaway, which is, I think, really interesting. So the first thing that they said is use an implant system that allows you to leave space for tissue, which we've already talked about, I agree with. Secondly, the average value of the mean height was 3.4 millimeters, while the mean thickness was 3.29 millimeters, with a relationship of 1.46. Therefore, with standard deviation 1.46. Therefore, the ratio between the mucosal height and thickness was found to be 1 to 1.19. So a ratio of roughly 1 to 1, right? Then they said there's this other study, they found it to be 1 to 1.5. I don't really care if it's 1 to 1.9 or 1 to 1.15. All I care about is there's a direct corollary between the height and the thickness, right? Meaning, in clinical practice, in the anterior, if we make a big fat abutment, we squash the width of the tissue, we're going to lose height, right? So if we starve out this tissue, it's going to recede. That's the takeaway for me. I need to leave horizontal space for that tissue to live if I don't want to see recession. So for me, this is a really cool study because it kind of confirms that what makes sense biologically, but we have a study that they did over a year and a half to show that. All right, and then the other takeaway or thing to consider there is once we lose that, can we get it back? So we put a big, ugly, bulky restoration in there and we get recession. Will it come back if we correct down the road?
If there's no bone loss.
Right, maybe, right? Yeah, if there hasn't been bone remodeling, it probably will somewhat, but it's way better to respect it from the get-go and never lose it, right? Because getting it back is iffy. It's probably going to require CTG grafting or something else. Okay, so now let's talk about, back to your question of what does that look like? So here's some different examples. Tissue level implants do really well with this concept because of the built-in emergence and all that. Generally, like if you look around those old Straumann tissue level implants, generally things look really nice, right? Because they follow all these biological concepts that keep the bone happy. What's the problem with would anybody do this implant for number 8 or 9? What's the issue there? Aesthetics, right? We've got very little, it is what it is, right? You don't have any flexibility restoratively to move things. You don't have, it doesn't follow the scalloping of the anterior. So it's an aesthetic issue, not a biological one. Okay, so we platform switch. You were asking about this earlier. We're moving this from here into here. So we're reducing the biological width horizontally. So instead of the bone seeing dirty connection here, we move it back here, and then that hopefully gives us enough biological width that we don't get vertical bone loss, right? So that's how the platform switch works. But for me, this is kind of like the holy grail, to have a platform switch, a clean connection, and then a concave subcritical contour that leaves lots of space for blood supply and for all this to live. And then we do a critical contour up here, the S-curve, for it to look like a tooth as it emerges. So we leave plenty of space for blood supply and for things to be stable, and then we make it look like a tooth in the last second where it matters, aesthetically, right? Okay, so say we place our implant nice and deep, and then we put something bulky on. We don't platform switch, and we starve this. What's the outcome going to be? We're going to get loss of soft tissue, maybe hard tissue, or a combo of the two, right?
So if you're putting something in there, let's say you're trying in a crown and you're getting blanching, but it's only blanching for like 5 minutes and then it regains coloring, is that an issue?
I don't think so, especially if you know the contour of the crown. So if you have a big fat tie base that's really deep, maybe, because all that blanch is happening down where it's critical and you don't even see it down there. If you're getting blanching up at the surface, it's probably doesn't matter, as long as all your contours are dialed, because you're going to get the blood supply back where it matters, which is foundational, right? And then we do know that, as you're doing those custom temps, by bulking it out a little bit, you'll push the tissue down a little bit. By making it a little thinner, so you play with it a little bit, but everything that matters, I think, happens more in this zone than up here on, towards the.
I think the issue that I've had in the past is like if the implant is not placed ideally and maybe it's lingually placed and you're trying to match the contour of the other anterior teeth, like it just poses a real big challenge to get that where you don't want like a ridge lap kind of like I hate
right.
doing anything like that, so you're trying to create that contour. So it's hard to know, like, you are necessarily thinning out that tissue.
Right.
And it tends to be like really tall tissue as well.
Right, and that's the hard thing, like you said, if you're going to place lingual, you need to place deep. Where you run into trouble with the ridge lap is if the implant's in the anterior, we always place subcrestal, because especially if you're lingual, you need running room to be able to make that subcritical contour and then come out, right? If your implant's up here and you got to be out here, it's going to be a shelf, and that's just not going to work well biologically, because we violate every principle we've talked about leading up to now, which is having enough height in the abutment, having those contours that preserve tissue width, right, to keep the height. So all that goes out the window if our implant placement isn't ideal for the situation.
Hey, Clark, that the previous slide,
Yeah.
what's the best way to convey that to the lab? Because you like the tie base with the
This?
That one, the tie base with the S curve and all that.
I mean, you can draw a picture if you want, of what you want. But if you work well with a lab and they understand these concepts, then it should be kind of just par for the course. I mean, another reason that tie bases get a bad rap is, as lab, it's hard being a lab, right? If you got 50 different systems that people send in, and you don't want to stock, and they want stuff turned around quickly, and you have to stock it, and you can't just order it and wait for it to come in. Especially during COVID, it was really hard with delays and things. What are you going to do as a lab? Most labs, if they don't understand these principles, they'll say, well, we'll just stock the shortest tie base of everything because I can always hide the shortest one, right? But what problem does that create if you got subcrestal placement and an anterior using the shortest tie base?
Fracture.
What's that?
Fracture.
Could be fracture. What's that? Yeah, we're doing this, right? We're putting a big, ugly, square thing down deep, and then we're causing biological width invasion problems potentially. We're strangulating the tissue by having a square, bulky deal there. So it's working with the lab and making sure they understand, we don't, as a lab, for Neodent, there's a rescue of 0.8 tall, but we don't like to use shorter than a 1.5 tie base, because if we're shorter than 1.5, we know that we're going to have a biological width problem, right? So we'll call the office and say, hey, what do you want us to do here? Can we put a 1.5 on and maybe it shows a little on the lingual? Are you okay with that, or do you want us to use the short one? So we let the office make the call, but we're cognizant of that, of not creating an iatrogenic issue based on our selection of lab parts. So we talked about that. Now, what if the surgeon is like, they understand the system, they're like, we're going to place subcrestal, and then they kick it back to a GP to restore, and they don't understand, and they put this big bulky thing subcrestal. So we can prosthetically really screw things up if we're not thinking about these things when everything else was set up. This might have been like a perfectly guided, perfectly planned, and then we put this big bulky thing subcrestal, we're going to have issues, right? We're going to get probably bone loss and tissue loss. So, we've created this violation here, and over time the body's going to respond by resorbing clear down, right? And then you might even have exposed implant threads showing. So these are the issues we see where when we're not thinking about biology.
That's when you just tell the patient they're getting older.
Right. So back to your question about how, what are we thinking, or how are we trying to design these? We break it down into two parts, a subcritical contour and a critical contour. The subcritical is where we're concave and we're trying to make space for biology, and the critical is where we swing out and try to make it look like a tooth, make it look aesthetic, right? So it's the subcritical, which I wish these terms were switched, because I feel like the subcritical is, biologically, is a critical component, right? But they're talking about patient perspective. It's critical to the patient how this thing looks. And we're supposed to know how everything's supposed to work down below where foundationally, right? Okay, so here's an example for you of what I think a good restoration should look like. This is just a simple premolar case, but we're trying to observe all these principles no matter where we are in the mouth, right? So we've got adequate abutment height. I think this is a 2.5 abutment, and then we've got another probably millimeter that's subgingival. So we've got 3.5 millimeters of running room in the tissue, which we know is going to be stable, and then we swing out here and make it look like a tooth where it matters, right? So if the gingiva sits here, the patient sees what looks like a crown. Does anybody notice anything else about this crown that we did to help prosthetically?
Took away the lingual cusp.
Yeah, right, exactly, right? So we've tried to compromise here. Looking at the occlusal scheme is always going to be a little different, but in this case I imagine we had, all the function here. We were able to leave a tall buccal cusp to make it look aesthetic, but functionally we tried to take the axial load off of it by flattening that cusp, because the patient's not going to see that, and it's going to help reduce our oblique loading. Can you hit that? Thank you. Okay, so this is a slide from our very own Dr. Seth Hewish. He sent me this, and he's like, hey, you need to put this in one of your lectures. So what's wrong with this tie base? Okay, so this is what you received, right? So why is this not going to be biologically compatible?
I think it's beautiful. It's very modern looking. It's square.
That's why you're here tonight, Russ.
Peanut gallery.
So obviously, this is going to violate everything we just talked about, right? The subcritical contour is going to get destroyed, and over time, it's going to plaque, or it's going to trap the plaque down there. It's going to squeeze off our blood supply, and we're going to get recession issues. So I think you did this chair side, right?
Yeah, it is.
So you hacked it up.
I like it.
Hacked it up to show the lab, like, hey, this is how you do it. Do it myself. So I don't know. I like this slide because I think it's a good representation. It's like, he uses healing abutment, gets his tissue perfect, and then this is what comes back from the lab. It's working backwards, right? So all the lab needs to do is take this, copy this, and we should be good to go, right? All right, so here's an example of an anterior custom. This is an older slide before we had angularly screw channels, so this was on a custom abutment. But you can see here, when I did this case, I purposely placed pretty deep, right? We're quite a bit subcrestal here in the anterior, because I don't know, in the anterior a lot of times I like to go 2 millimeters subcrestal to my buccal bone, and a lot of times the interproximal bone could be 3 millimeters taller than the buccal bone, right? So this sweeps down. So this looks really deep here, but it's going to sweep down on the buccal. So I want to make sure I'm subcrestal there, and if we get a little remodeling, we want to have some running room too. That gives us more prosthetic flexibility. So now we've healed up. I went to put this abutment in. First time, I was getting impingement here, right? So I could have forced this home and seated it that day, but what would that have done?
Are you actually getting blanching? You mean when you're actually seeing blanching?
Yeah, I'm getting blanching, but I'm getting blanching deep, right? If I'm getting blanching up here, I'm not that concerned about it. I'm getting blanching here, I'm worried about it. So what I did is I sent it back and I had it remade with a very straight contour, no width here, and then all the width coming out up high, right? Or up towards the surface. So that's really where my head's at when I'm thinking about this is I want my subcritical contour to be like very, very minimalistic, right? And then sweep out with that S curve as we get to the surface. And that's where we're gonna have good stable outcomes.
How do you know if it's blanching down there? Is it just radiographically you notice that?
Yeah, and it's, the feeling of when you're seating it. Yeah, I don't know how to answer that question.
Push to get it in.
Yeah, it's kind of an experience-based thing, but it's also, when you have a nice, it could be painful to the patient. Visually when you're looking at it, you want to see either straight or curved, and then you think concave down below, right? If there's anything bulky coming out of your implant down below, anything bulbous, that's wrong. Because we don't want to be putting, so this is pretty nuanced here, but that's exactly what we have here on this one. See how instead of coming straight out, it has this little bump here?
Right.
So would it have been okay? Maybe, probably, I don't know.
The abutment's shaped, but not the...
Yeah, so the abutment, look at the abutment, it's straight, and then it comes here. So this does this little hump here, and then it comes out. So all I had him do was take that little hump off.
Okay.
See here, because we're like pushing right up against the tissue. Here we've got a little bit of space. So it is nuanced, but once you get it and understand the principle, it's predictably applicable across the board. Okay, so from all that minutia, what are our takeaways? What really matters clinically about all this? I think using anatomic healing abutments from day one, time of placement is really important. Also, the other thing is grafting. Always graft the gap. If you're doing an immediate placement of an anterior, always graft, because the studies show that that's going to limit the resorption that you see. And also never flap. Where does the blood supply come from on that buccal bundle bone? It comes from the gingua. There's one other source. Yeah, so periosteum gingua would be one. The other is PDL, right? We take the tooth out, what do we lose? PDL, no blood supply there. We flap, what blood supply is left to that bundle bone? Is there medullary blood supply in that bone? No, there's not. It's too thin, right? Because it's like a millimeter thick. It's all cortical bone. So if you flap and you tear that tooth out, you've removed all the blood. The only blood supply it's going to get is reperfusion when you lay that flap back, right? Which may or may not be great, and it depends on how long you've had it open, how much blood of starvation has been there. So I really am an advocate of anterior immediate placement. Don't flap, because if you can keep that buccal blood supply intact, take the tooth out using modern technology, luxators, approximators, a thin diamond or thin carbide in a surgical handpiece, all those other techniques, and not flapping, you're going to keep that blood supply in place. You'll have better outcomes. And then implant placement, of course, this isn't the place to talk about all this, but implant placement, leaving that buccal gap and grafting that gap, dual zone grafting, I'm a big fan of, because you're going to really limit the resorption that you see. You'll get good outcomes most of the time.
You don't flap when you do put a membrane.
What's that?
You don't flap then, after you put the immediate, any type of membrane or anything like that.
So I usually advocate a dual zone graft where you use your graft material all the way up to the top of the soft tissue. And then you'll get, using I like to use osteogen for that. Because we know we're not going to actually grow bone up to the top of the tissue, but that collagen in that product is going to integrate the tissue and thicken the tissue and keep you from getting tissue thinning.
You put the osteogen inside the gap and all the way up to the top.
All the way to the top. I actually have it sticking out of the top of the gingiva. I'll screw my anatomic healing abutment down to lock it in, and then I'll just trim any excess off the top, at the top of the gingiva level.
So you wouldn't need it with a cortical cancellous or anything like that? Or you find
If it's a healthy socket, I just use that osteogen product for the whole thing. You could do cortical cancellous all the way up to the top as well. And the other thing that's important is suturing, using a horizontal mattress suture to kind of cinch it closed like a belt. You put that through and it just will suck the tissue up so you don't get junk down in there while it's healing over.
you think PRF would also have similar?
PRF would be awesome too.
Yeah.
Yeah. Yeah. Because PRF, we know, what does it do? It eliminates infection. It causes the tissue to heal more quickly and thickens the tissue because you're getting cell signaling to the site to regenerate, right? You're not going to grow bone with PRF, but it's going to limit your infection and it's going to cause things to heal more quickly. So yeah, always a fan of PRF. I use it on every arch. All right. So the other thing I think we've drilled home now is a concave subcritical contour, right? Making it concave below the tissue and then coming out at the last second. And then the other is once we've screwed this up, it's going to be hard to come back and undo that, especially in the anterior, especially in the high smile line, thin biotype, nervous, high needs patient, which always seems to go together, right? Okay. So, where are we at? I don't even know what time it is. Phew, man, we gotta wrap it up here because we still have some other stuff to do. Okay, so, but great questions that got me a little off topic. We'll try to get back on here. So really, it comes down to understanding these principles, and proper diagnosis is way more important than trying to fix it later. So Dennis Tarnow said tissue is the issue, but bone sets the tone, right? So our soft tissue is a product, like you mentioned, of our bone stability underneath, maintaining healthy bone, which we just talked about surgically, how we do that.
Did he really say that, RSM?
He did really say that. And you know what, I think I've got more stuff here, but maybe we work this into another night because I really want to get to the hands-on. So let me just go over, we'll look at this stuff later, but let me go over our digital workflow real quick. That shouldn't take too long. And I'm going to do that from here so these slides will work. So here's our patient, super nice guy, missing a tooth obviously. So for this case, we're doing a full digital workflow, right? And that includes the treatment planning. So first thing we do is we take scans and we take a basic photo series just using an iPhone camera. And then we pull this into exocad. And we're going to use digital smile design within the software to create our predicted outcome. Right, so we'll align that, set our lips, set our STL files, which come from our intraoral scans, and then we're going to place our tooth digitally, and this is going to give us a lot of information. With this placed, what issues do you guys see with this case?
Your angle of the implant is going to be coming out the facial of your crown.
Yeah, so there's obviously some deficiency to the site, right? So the patient history on this is he's had a flipper for 10 years. So he's been missing this tooth for a long time. How about we can't see that yet, but we'll look at the occlusion here. So, this gives us something we can show the patient. We can print this out and say, hey, this is the outcome with no grafting. Are you happy with this? Because he has the bone, but he has a saddle defect. It's like, are you happy with this, or do we need to graft first? And this guy's like, I haven't done anything about this for 10 years. Whatever, I just want a tooth. Super low needs, aesthetic needs. So in this case, we decided, you know what, his tissue type is good enough. So despite this defect, we're just going to proceed. There's plenty of bone, and he really doesn't care how this thing looks. He just wants a tooth back. He wants to quit wearing a flipper, right? So we do this workup, create a model on that, and we place our tooth. And now we're able to look at occlusion. What occlusal issues do we see? Yeah, so he's been missing this tooth for so long. We have some hypereruption of the lower. It looks like it's drifted facially a little bit. So we've got an occlusal interference. So we can discuss that with the patient, say, hey, look, you could do ortho, we could move that tooth, or we can just place the tooth a little facial. And again, he's like, yeah, whatever, just fill the space. I don't want to go through all that. Okay? But at least, by doing this, what have we done? We've set the expectations, we've documented the case. There are no surprises when we get to the end. Otherwise, we place the implant 3 months later, it's, hey, sorry, man, as opposed to leading out with this. So now we have a model that we can go off of. We know where we're going to end up. We can print that model. We can show the patient. We can also pull that model in to a surgical guide design protocol if we want to. So surgical guide design, we're matching the STL of the mouth with the data from the scan, right? So we do that match, and then we can actually place our implant in a completely prosthetically driven workflow by using our model imported into the guide design software. So we'll place our implant in here and then just look at, okay, where's the bone? Is this going to work out? Again, plenty of bone here. And prosthetically, we can do this actually with the screw retained to the lingual still. So that all looks good. So we'll now make our guide. We design the guide. And then we can 3D print that guide and then take that to surgery. So here's our guide ready to go for surgery. So we used a direct fit to the key here, using the key as the sleeve. So because our printers are so accurate now, we can go sleeveless, which is kind of cool. One less part. There's all kinds of considerations around surgical guides and things that we need to watch out for. I'm going to kind of jump over that for now, just based on time. We can talk about that another night too. Because I want to get to the rest of this. Okay, so then we go to our surgery. We're going to do just a mini flap. I like to always preserve the KT. I don't like to tissue punch because you're going to lose keratinized tissue. So in this case, you probably could have tissue punched, but he's deficient, right? So I want to try to take this as an opportunity to augment the tissue a little bit. So we'll flap, we'll place our guide, and then we use these windows to make sure we're completely seated. And we'll put our key on and we'll go ahead and place our implant. I always use this a little probe after my pilot just to make sure there's no fenestration, especially when I don't have a full flap, because you want to know if you're in the wrong place at this point, not after you drill a big hole, right? So then we'll size up, we'll place our implant. In the anterior zone, my personal preference is to use a hand driver because you get tactile feedback. You get more feedback on your angulation than if you use a handpiece or a driver to place. In the posterior, it's not usually possible due to access, but whenever possible, that's my personal preference. So now we've placed our implant, we've placed it. The neodent, it tells us how deep we are, so we're 3 millimeters subgingival right there. And then we'll check it, we'll check our torque, make sure we have sufficient torque for immediate load. I always get a CBCT of every case same day to make sure that my implant is where I think it is. Because patient management wise, if you're not, you'd say, hey, you know, things look pretty good, but I want to make them perfect, which translates to the implant's out of the bone. I got to fix this before this patient leaves, right? If they leave and they come back for a 2-week post-op, are you going to tell them, hey, we got to renumb you, and we got to, then it's like very obviously a serious complication, right? If we can fix it day of, then that's a huge win for everybody. They're still numb, they're in the office, it's still part of the procedure. So anyway, we have this implant placed. We're going to go ahead and scan now. So we place our scan body on, we get our scan, we throw a healing abutment in here just to keep things good meanwhile. We are using this, Straumann had us do some testing with this product. It's similar to Osteogen. Yeah.
You scanned day of surgery?
Yeah.
On that one?
We're showing a digital workflow on this with an immediate digital temp.
It'll work.
Mm-hmm. Yeah. So here's the, now we'll take this to the software, and this should answer some of those questions earlier about scan bodies. So this is our scan, and then on that bottom left in exocad is the file, STL file that the software generates. So it's just going to surface match those two. So it places it over the top of it, and it's just trying to say, okay, let's line these two meshes up as closely as possible. So if you have a bad scan of your scan body in the mouth, it's not going to be able to do a perfect job of matching those meshes. Does that make sense? Because then it uses that mesh match to tell the software exactly where the implant is. So the cool thing is we have our pre-op, right, from our workup that we can overlay to say, okay, this is where we wanted that tooth, and we can verify that we placed the implant right where we wanted it prosthetically, which is kind of cool. And then we can take that and we can design our temp. So this is our temporary restoration that we've designed based on that scan and based on our pre-op workup. So we'll place that in there. And then something that I like to do in immediate temps is make a lot of room for the papilla. So we'll really exaggerate that, making that subcritical contour really open. So you can look at our pre-op, and we're more reduced in this temp, right? Because I want to give the tissue every chance to fill that space in this healing temp. So then we generate this file. We take it to the 3D printer. We're going to print that out. So, you know, these little teeny crowns that print out. And then we're going to stick that on the tie base, and we're going to cure it as one unit. And the resin is going to act as the cement. So there's no cement. It's just cured straight to the tie base. And mechanical retention keeps those two parts together.
So you're taking it off your 3D printer with the excess resin,
Mm-hmm.
putting it in there, make sure your screw channel's closed, and then curing it in the box.
Yeah. Yeah, so we're wiping it with a towel, but we're not throwing it in the alcohol bath, right? All right, and then we're going to add a little bit of character to dress up the color, make it look like a tooth. There's just some OptiGlaze on here. This whole process takes, it's probably like a 10-minute print time, design times 15 minutes, 10 minutes of characterization, 5 minutes in the cure. So, I mean, you're looking at probably an hour, to turn this around. But then we're going to place that on there and let it heal up. So he heals up into place here, and that allows us now to guide that tissue maturation. So we're just kind of starting with the end in mind. Now, I don't do this all the other really important thing, right? Like, especially with this guy's bite, we don't want anything touching. So we make this temp extra short, right? And he's an excursive and an MI, making sure that nothing's touching. But he's over the moon from where he started, just with this temp, which is not that great. But so we'll let him heal up like that for 3 or 4 months, and then we move to final. But we know pretty much where we're going to end up before we start.
What's your minimum torque value for an immediate?
For me, like 45 to totally load it like this. If it's like above 30, I'll put a healing abutment on it. But yeah, it's got to be pretty good there. All right, so that's kind of the working through the digital workflow there. Any questions on that? All right. Well, appreciate you guys all coming. We have also the hands-on part of it here. I know it's already 8, so I'm going to have Jessica kind of run you guys through that. If there's anybody that's already familiar with Neodent and they're like, I'm good, we won't be offended if you need to take off. I will say though, if you want CE credit, make sure that you got your name on here.